Hi everyone, good morning and welcome to the Shri CPD program. Today we are conducting the 216 CPD program by the Shri. The webinar link will be available from 9 a.m. to 9:50 a.m. to join in. The late attendees will not be entertained thereafter, and each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and CPD points are strictly adhered to the NCCPD guidelines. We hope all of you follow the guidelines. When asking questions, you can ask the questions at end of the webinar. If you have a question, please type into the chat, and please change your chat settings to all panelists and attendees so your question can be answered. If you have very specific questions about your situation, please email us on office313@gmail.com. So today's topic is approach to the floppy baby with pathophysiology of tone or hypotonia. And today our esteemed lecturer is Dr. Anuruddha Padeniya, consultant pediatric neurologist, Late Ridgeway Hospital of Children, Colombo.
Thank you for kind introduction, Telash. I wish you all the best for the new year and hope that you can see the screen. Floppy baby is a very important topic, I think, especially for pediatric clinicians who are handling children, especially the neonates and then in the first part of their life. It's very important that the floppy baby to understand the basic principles behind the floppy baby. And the topic will cover basically the pathophysiology behind what this floppy is all about. But very interestingly, this topic covers the entire neurology, starting from the brain down to the muscle. We will see how we are going to differentiate to basically identify what causes the floppiness in the child and what ailments and how we are going to manage the child. So first of all, I think we have to take a few minutes and to understand what is this muscle tone, the basic principles of tone and then the hypotonia. Then I think as a clinician, it's very important that how we are going to see whether this child has hypotonia or not. So with very confidence that and how we are going to confirm that whether this child has hypotonia. Once you do that, then the next step that we need to follow is to see what causes this hypotonia, or we call it the diagnosis. So diagnosis first will see what area is affected and then the specific diagnosis. So we have to discuss the practical approach to a floppy baby. Then we will have, this is a 2-hour lecture, I have confined it to 1 hour. So some of the conditions in very brief we will touch, and the management principles we will touch, because as I told you, it's a very broad topic. And if you were to discuss the entire management, that itself will be a complete lecture. So basically, the lecture will confine to understand the basis of this, what is this tone and how we are going to clinically demonstrate and the practical approach. Updates and summary sheets, we will have to drop in. So first of all, understanding what is tone and the basic physiology behind the tone. Now, you know, there are several words used, hypotonia, hypotonia, or you call it spasticity and rigidity, then myotonia, dystonia. So various terms are used, and then the normal tone. So how this tone is basically built up on your body and for what purpose is what I am going to discuss on the very first day. Now, muscle tone. So how are you going to discuss? Yes. So basically, what is the tone? So muscle tone is, you can see it's the tension in the relaxed state. That is what you call by tone. So tension in the relaxed muscle. So what is important thing is, and when you are going to be relaxed, maybe sleeping, maybe relax on a posture, and during that period, if you are not dead or if you are, you have to maintain a tone, or we call it the relaxed tension of the muscle to safeguard yourself from the posture and in the during the movement to look after your balance. So you can see this simple definition of tone is described as resistance to the passive stretch. And when it is on the active stretch, it is we will discuss it later. So it's a physiological state in order to maintain your posture during the relaxed state. And then when you are active, the balance and then the movement had to be facilitated by the tone that you build up. So to maintain tone, what elements are basically involved is very important. You can see in this article very clearly says you have to have the muscle to maintain the tone. That is the operating mechanism of the tone. And then the muscle will be divided into various components to maintain the tone, and that had to be balanced and operated from that angle. But then again, to maintain the tone, it's very important that you should have a regulatory pathway. So the regulatory pathway is usually discussed under the spine and the brain. So therefore, we can call it upstairs control is always there to maintain the tone. With regard to the brain, there are several elements involved in regulation. So basically, what we have to tell is to maintain the tone, you have to have the muscle in action, and then the regulation by the spine and then the brain. So disorders of the brain itself will ultimately reflect as tone imbalances. So that is what we are going to discuss. Now, the definition, of course, the tension in the relaxed muscle state, and then the network, as I told you, in the muscle, you have the muscle spindle, which will basically inform the spinal cord about the current status of the tension which is maintained in the muscle. And then based on that feedback or the response or the stimulation, the spinal cord will reflect their reaction into it. And at the same time, there will be a regulation from the supraspinal, or we call it the brain. And because of that, if the regulation or the muscle activity is not going to be optimum, you will have less tone. Then you call it hypotonia. If your activities cause high tension in the relaxed state, which is not expected for a normal child, it's beyond that, then you call it hypertonia. And in practice, we call it spasticity, or according to the pattern, you might call it rigidity. And when the regulation is not in the proper form, ups or downs or variations, then you call it dystonia, and then various paratonias are being discussed. So today's topic is going to be floppy baby. So basically, we are going to concentrate on the hypotonic element, or how hypotonia is generated in the process. As I told you, what are the bodies involved, or what are the organs involved? As I told you, the muscle is the most important thing. That is the operating platform of the activity. So in the muscle, we have to concentrate two things. The sensory pathway, or we call it the muscle spindle. So within the muscle spindle will report to the spinal cord what tension that they are maintaining at the moment through the group 1 and group 2 sensory fibers. But at the same time, when the tension goes up beyond the point, based on the feedback from the spinal cord, you should have a safety mechanism. So safety mechanism is attached to the tendon. Actually, muscle is going to get attached to the bone through the tendon. So in the tendon, you have an element called Golgi tendon body. So these elements are available in the muscle to maintain the tone. And then coming to the spinal cord and the supraspinal regulation part, the latter two parts are regulation, are maintained through alpha and gamma motor neurons to inform the muscle to maintain the tone. So I will tell you what is the role of the alpha and then the gamma motor neurons. And then you have the supraspinal control. Now, the supraspinal control is the corticospinal fibers, is what you all know basically. But in addition to that, the basal ganglia will get involved, and then there's a reticular system in the brainstem. Then the cerebellum, of course, definitely going to join hands with that. And ultimately, you get various types of hypotonia depending on the deterioration or deviation from this basic principle. So in summary, in the muscles, there are two elements to regulate the tone, and not to regulate, to activate and sense the tension. That is the muscle spindle and the Golgi tendon. And for the regulation, there are two elements, that the spinal cord and the supraspinal control. So there are four elements basically all the time acting, because in the resting state, to maintain the tone which you entertain at any moment. Now you can see in this picture very clearly that sensory motor fibers are reporting from the muscle spindle, and it is reported to the spinal cord from the posterior region, and then the motor activities are released from the anterior region, from the spinal cord. So let us see much more detail. Now, in a muscle, you have muscle fibers. These muscle fibers all are not going to work as sensory organs. So sensory organs are maintained or confined to a wired set of muscle fibers. We call it intrinsic or muscle spindle. And then we call it intrafusal fibers for those fibers. The fibers which are not wired to give that sense but work to maintain the tension are called extrafusal fibers. So there are two types of fibers based on whether the sensory organs are attached or not. Then you can see down there in the tendon itself that you have the Golgi tendon, and that will report and that will work as a safety mechanism. When there's overtension is taking place, the Golgi tendon will look after that part to maintain the tension, not to break the muscle or not to damage the muscle. So these are the two elements of sensory organs which will go and report to the spinal cord. Now, during the resting state, all these sensory organs are keep on informing the spinal cord with regard to the current tension of the muscle. Then, as I told you, the extrafusal fibers, we call it extrafusal fibers, the fibers which are not wired like for sensory, are going to do the contraction, and that contraction is felt again by the intrafusal fibers, and they will keep recording to the spinal cord with regard to the current tension of the muscle. And if it is going over, the Golgi tendon will take place, and the Golgi tendon will ultimately report it to the spinal cord to reduce the tension to allow not to harm them. And you can understand this is a asynchronous discharge to maintain the tone. Now, when you are going to tap, you call it the tendon tap, then there will be synchronous activity. I will explain that in a moment. So basically, the resting tension of the muscle is maintained as an asynchronous activity. So therefore, with regard to the extrafusal fibers at any given time, all fibers are not going to maintain the tension, and they are taking turns to maintain the tension. But when you are going to tap with the knee hammer, all extrafusal fibers work in one go. So therefore, there will be exaggerated reflex when you are going to tap with your tendon hammer. So with regard to tone maintenance, as I told you, basically so far we have explained what muscles activity with regard to the tone maintenance. But as I told you, with regard to the regulation, we have the spinal cord, and then the supraspinal control will come into effect. Now, the contracting activity is called myotactic reflex. And as I told you, the Golgi tendon, the safety mechanism is called inverse myotactic reflex. So both these reflexes are important to maintain the tone and then not to harm the muscle by over maintenance of the tone. So both are working hand in hand. So we can explain that there is an excitatory pathway or inhibitory pathway within the muscle itself through the spinal cord reported in order to have a normal tension of the muscle in order to maintain your posture and the movement or the balance. Now, this inhibitory interruptions of the stretch reflex, any level of the motor neuron, then you will lose the muscle tone. So obviously, the tone had to be, the spinal cord will have to send their information or the messages to the muscle to do that. But if there is a damage to the lower motor neuron part, definitely the muscle will not get that information to maintain the tone. And interestingly, the supraspinal influence I will discuss in detail, but mainly it is inhibitory. So obviously, when the supraspinal regulation is no more in action, what will happen is there will be hypotonia. The tone will go up in order to cause this, we call it rigidity and spasticity in our terms. So you can see in this cartoon, when the muscle is stretched, you can see the muscle is now normal and it is stretched. Now the information will go there, the spinal cord from the posterior column, and then it will be reported to the supraspinal region, or we call it the brain, and then the motor activity will go down. Now, in case if there is a damage to this motor activity, obviously there won't be any tone maintained. So ultimately there will be hypotonia, but if the brain connection is going to be disconnected, what will happen is there will be hypotonia, because the inhibitory part, mainly it is inhibitory. So what is the purpose of this maintaining tone with these whole 4 elements working all the time, and even the resto activity, they are fully in action? Why it is so important? It is very important to maintain the posture of your body. And if you don't have that, you will have seen in kids when they are hypotonic, they can't maintain their posture and they are dropped, and they will be they will not be able to maintain their posture or seated posture or standing anyway without any help. And when you are in move, it will prevent you from getting danger, and it helps to maintain the balance. This is in the resting state, the posture, and when you are in movement, the balance. So this is the purpose of maintaining this tone. It's a very important activity of the body. And you can see, I told you, when you are tapping with the tendon reflex versus in the normal situation, why the muscles are and legs are not jumpy when you are on the resting state? For the simple reason, when the afferents are going to the muscle, in the tendon reflex, it will be annulospiral ending. So 1A fibers will be supplied, and almost all the extrafusal fibers will go into contraction in one go. But you can see type 2 fibers are working on the free time or resting time. Then it will be flower spray ending. That's how they say. Only that some of the tendons are working, so it takes turns. So it's like a water flow from flower spray endings. That is why resting tone can be exaggerated by deep tendon reflex, and you make yourself more and more less tense by doing various activities to make the tendon reflex more and more elicitable. You can see the supraspinal regulation is not that simple. This is what they explain, but in total, you can see the premotor cortex, motor cortex, pontine, and the lateral reticular formation, lateral vestibular nucleus, medullary reticular formation, all are in action. But basically, in total, what will happen, the summation is that it will be a negative inhibition. So because of that, when the supraspinal control is no more, what will happen is there will be spasticity and rigidity, and what will ultimately end up with contractures, and because the movements are completely different. But if there is a problem of these regulations, you can see how many elements are working, then you call it dystonia or paratonia, depending on the pattern that is generated in the game. That is out of the topic at the moment. Right. Having said that tone is maintained in the muscle, then the spinal and the supraspinal control, and how it is going to get reflected on the basically on the muscle. Ultimately, as a clinician, what you need to do is you have to learn the competency to demonstrate the hypotonia. And when you are going to demonstrate hypotonia, you have to be very smooth as a pediatric trainee. And very importantly, you have to do without hurting the child, because the child is hypotonic. Child can't maintain the posture and the movement on their own to an efficient level. So because of that, the way you are handling the child might be not civilized for a trainer to give you marks. So therefore, it is very important that very smoothly learn the technique and to do clinical demonstration of hypotonia. How we are going to do that? Now, very importantly, you have to learn the background history, age, and the maturity of the appropriate muscle tone. It's very important, because whether the hypotonia needs to be eligible or not. When now more and more preterm babies are born, some of the preterm babies, this mechanism of maintenance tone has not yet developed. So therefore, anyway, they will hypotonic, need not to differentiate it or demonstrate it when they are so young. We'll see. So at rest, what you have to know is you have to see the posture, and then during the movement, we have to use the clinical manuals to diagnose them. Right. You can see when a child is born, if the child is premature, the tone basically developed at the 32 weeks. So up to 32 weeks, child will be anyway on the hypotonic posture. So hypotonic means their hips and the knees are extended, they are not flexed. So at 32 weeks, basically their hips and knees get flexed. So that is the beginning of starting reflecting that you have a good tone. But at age of 34 only, that their hands also start working, and they will show that they are not hypotonic. So all extremities will be reflected at age of 40 weeks. So therefore, only the term babies are suitable to show the entire picture of tone, the normal tone. But that the tone reflection will start from 32 weeks. So if you are less than 32 weeks, obviously you will not, or you will anyway have hypotonia. You need not to demonstrate hypotonia on them. So clinical demonstration of hypotonia. So as I told you, you have to get the history from the mother and the maternal records, and you have to observe the child, the posture, and then the maneuvers or the movements. Then hypotonic demonstration, they talk about the head lag when you are pulling to sit, then the ventral suspension, and usually the term used is the ragdoll when they are hypotonic, and then you the same way you go for the ventral suspension from ventral suspension to vertical suspension, and you might have the element called slip through and then the calf sign. So we'll see how we are going to do this manual. So therefore, in the history, you have to see whether there had been a delay in their stages of labor and what medications and drugs that mother have used, and whether there is any element of congenital infections or perinatal infection, feeding, and difficulties in their cry. So with that background, and especially going into the antenatal period, that you will see whether the fetal movements, how the quality and the quantity of the fetal movement, and whether there had been polio or oligohydramnios in the perinatal, how they are, whether their presentation was breech or whether they had birth trauma, whether there are any complications and then postnatal complications. And you have to visit that and see whether you can account it to the hypotonic element. Then after getting that history, you see the posture and then the movement. So the posture is inverted C shape, is what you call that they can't maintain the tone. You can see the normal child is maintaining without the inverted C shape, very straight, but the rounded back arch in the sitting position, and we'll be able to observe when they are seated. And you can see the child, usually their hips are flexed, knees are flexed, hands you can see they're in the flex posture, but these and then the arms are abducted when they are lying supine. So these are the things which are going to miss in demonstration of hypotonia. We call it the frog leg posture. You can see their tone is not maintained with that flex posture, and you can see it's abducted and rotated outside the hands and then the legs, and you can see that they are struggling to maintain their tone, and then you suspect that this child is not maintaining the tone, so you call it hypotonia. Now, in the process of clinical demonstration, you have to do it smoothly, I told you. So what are the 4 maneuvers of that clinical demonstration that you are going to do? We'll see. The first maneuver, after observing that whether the child has inverted C shape and then their extended posture and abducted posture. Now
we can again look at the tone of the neck as we do traction and pulling on the baby. See how well he can bring the head up off the mat. You can see he's having difficulty with that, which reflects again lower tone.
You can see when they are being pulled, they
in the
can't
neck,
maintain the tone of the
and then we can bring it all the way up to the upright position.
You can see
And his head falls forward, and we'll just see if he can bring his head back up. You should be able to do that within 30 seconds.
On backward, and more importantly, you observe the legs also. In a normal posture, they have flexed their legs, but in a hypotonic child, extended leg and abducted extended legs are also seen on this picture. Then once you do that, the same child, you do the ventral suspension. You keep your hand underneath the chest and the abdomen, and then you do this maneuver. We'll see how that maneuver is being done.
We're now going to look at ventral suspension. We're going to turn the baby over on his tummy, and we're going to see how he can extend, how he can maintain axial tone. Here he's draped over my hand, his head comes down fairly close to my hand. He should be able to extend his head a little bit better. He's trying there. That's good, though. Should be able to extend his hips a little bit more. But again, he's pretty well draped with the legs somewhat flexion, the arms somewhat in flexion, but just more extended. Usually, a typical baby will be more in flexion at the extremities and have a little bit more extension at the hip and at the head.
So I think you will appreciate the head or the neck, and then the hands, then the legs and the trunk. So all are elements that are differing from a normal child to demonstrate hypotonia. That's the next step. Then you do the vertical suspension.
Now we're going to go to vertical suspension, and we're just going to hold onto his shoulders and be able to see how he does as far as holding him up. And again, his shoulder girdle should make it so that I don't have to keep trying to hold on to him, which I'm having to because he's slipping through because he's got lower tone at the shoulder girdle. And it's still pretty well in extension as opposed to being in flexion. So this would be lower tone in the shoulder girdles, in the shoulder.
So it is called slip through because there is no resistance from the shoulder girdle to stay with the support of the hands of the examiner. So basically, what you have to understand is they have to very smoothly have to handle these children in order to, because otherwise the parents and the other caregivers might get upset and they might not trust you if you do in a very rude manner. Then the last point is the scarf sign.
At this point in time, we're going to look at the tone in the shoulder girdle by doing the scarf sign. I'm going to move my hand so that we try not to get in the way of the camera. We're going to take the hand and pull it across the chest, all the way over here to the shoulder, and see if we can bring it beyond the shoulder. We get a little bit beyond the shoulder. We can certainly bring the elbow to the midline of the chest. Now, for a full-term infant, this reflects tone that is low, so this is hypotonia. We can do the same thing for over here. Again, pulling the arm across the chest and to the shoulder, and again, this arm comes well beyond the midline, not to the shoulder though. So some tone, but lower tone than what we'd normally expect in a full-term infant.
So obviously now these are the activities that you do to demonstrate hypotonia in the clinical setting. You can see first you get the history, then you observe the posture, and then ultimately you do these 4 manuals to diagnose. So basically now we are very clear and we are very confident that this child has hypotonia. Now once you get to know that child has hypotonia, then you have to trace what are the causes. As I told you, now when you are going into the diagnostic approach, again we go back to the anatomy, how it had been differentiated. I told you the muscle tone had to be maintained, and the regulation is from the spinal and the supraspinal regulation. So definitely, then the pathways to the muscle, sensory pathways goes and reports it. Then the motor pathway is going to get operated to give the tone, the resting tone of the muscle, and we call it the normal tone. So to maintain, so the supraspinal and then the lower motor neuron or the from the spinal cord, the muscle should act. Now, if there is, depending on these sites, we will be able to differentiate in the diagnostic approach, what part of the neural system is involved. In teaching neurology, this is the basic structure that I used. I divide the neurology into 10 elements. So what are the 10 elements? You can see this is 7 elements are basically anatomy, and last 3 elements are basically management purposes. You can see, you call it upstairs to the brainstem, cerebellum, and the spinal cord. 1, 2, 3. Then there are another 4 elements in the operation. That is, you have the anterior horn cells, nerve, then the neuromuscular junction, that is the chemical pathway from the nerve to the muscle and in the muscle. Then for the management purposes, it is very important that number 8 is the bulbar involvement. You can be the swallowing and then the speech, and then the other movements are involving in the bulbar is very important. Then the sphincter elements, that is the anal sphincter and the urinary sphincter. That is very important in the management purposes. Then I put which are not directly under any of these categories, but more or less using almost all or some of the elements under syndromes. So these are the ways I simplify neurology. Then when we are going to diagnose a child, it's very important what part of the neural system is involved. This is the algorithm that you will be able to use, and then you will not have confusion, but you have very good clarity in your mind what part of the brain, that neural system that we are discussing. So putting this into the principle, you can see that in the hypotonia, the usually teaching process takes place from central causes and the peripheral causes. So what are the central causes? The brain, cerebellum, and the spinal cord. And what are the peripheral causes? Starting from the anterior horn cell, then whether there is impact on the nerve and the neuromuscular junction or muscle. Very importantly, a couple of weeks ago, I did acute flaccid paralysis lecture. Basically, when you are going to discuss the acute flaccid paralysis, the topic is going to cover the acquired conditions. Here, of course, the floppy baby, floppy neonate, or floppy infant is going to cover basically, rather than the acquired causes, mainly some congenital, inherited, or perinatal related issues are being discussed under this heading. So today's topic is going to cover all these 7 elements of the neurological system, but mainly confined to the perinatal issues or inherited conditions. Now, this is the anatomy of the brain, and then coming to the spinal cord and then to the muscle. This, of course, you know. So anatomical differentiation in the hypotonia basically taught from the perspective of the central causes or peripheral causes. That is the first thing that in the algorithm that we will do to identify whether we are in the central region or peripheral region. Having said that, then you have to go for the specific diagnosis. Central causes, of course, coming together, like rather than differentiation won't happen in the usual clinical practice apart from a neurologist. But in the peripheral causes, of course, you have to have the competency to see whether it is a nerve head or anterior horn cell problem, or whether the nerve itself, the myelin or the axonal problem, or then again, the neuromuscular junction is the chemical transmission of the information, whether there's a problem of that or the problem is in the muscle. So as I told you, all 7 elements are going to touch in this topic. Now, how we are going to differentiate whether it is upstairs problem or downstairs problem, or call it central problem or peripheral problem. Now, usually, as I told you, in the periphery, if it's a peripheral problem, obviously, the message to the muscle, the motor message to the muscle will not go. So therefore, in addition to hypotonia, that muscle will be weak. But if it is an upstairs problem, if it is a central cause, definitely the motor pathway is still intact. So therefore, the muscle will not be weak. So the body, though the resting tone is being distorted, still the voluntary control and the strength can be maintained on the muscle. So because of that, that aspect is used to differentiate central causes and the peripheral cause. So therefore, we have to see the muscle strength to see, and coupled up with the hypotonia to see whether it's a central cause or not. So you can have 2 ways. Hypotonia, now you have demonstrated and you are very confident that you are dealing with the child with hypotonia. whether this child of hypotonia is weak in their muscles. So then it will be peripheral causes. The peripheral supply to the muscle supply or the motor supply is in trouble. But if that is intact, what will happen is muscle strength will be preserved with hypotonia. Child will be look hypotonia, can demonstrate hypotonia, but the muscle strength is maintained. So therefore, based on the whether there is floppy child, whether the muscles are weak or strong. So we call it strong hypotonia and the weak hypotonia. So then how we are going to demonstrate the weakness? That's the next step. Otherwise, we will not be able to differentiate strong hypotonia and the weak hypotonia. So if it is weak, what are the elements and how we are going to maintain the strength? So usually, as I told you, muscle tone is the tension maintained in the resting state. But the strength is when you are doing action. So usually, you demonstrate it by using the resistance. You ask the child to move their hands or other limbs against the resistance or against the gravity. Then you observe. But in this case, floppy infant, of course, you will not be able to have the privilege of applying resistance to a neonate. You might damage the bones. So because of that, that only step that is available is just to see how the child is moving themselves against the gravity. And very important to understand the principles behind the muscle tone and the strength. The tone is the amount of tension in the muscle rest. And strength is what the muscles do when not on rest, when on action. And very importantly, muscle tone is controlled by the brain and the unconscious level. You need not to work out your muscle tone, but definitely muscle strength that you have to put your inputs and you have to be conscious throughout. And muscle tone, you will not be able to increase or decrease through exercises. But obviously, as you know, you might be going to gym and other places to do workouts in order to improve the strength of the muscles. Usually there is 0 to 5 scale that you can see in order to analyze the muscle strength. But unfortunately, you are not in a position to do that with these kids because the children are either neonates or infants. So you will not be able to apply that rule here. So because of that, what we are left with is to see whether the child is observed and to see how that child is reacting to the gravity. So there will be ultimately, test will be limited to pure and simple observation rather than maneuvers with regard to demonstration of the strength or the weakness. Now, hypotonia I told you to demonstrate, and once you demonstrate the weakness or the strength of the muscle, then you will be able to differentiate whether you are dealing with the neonate with the strong hypotonia strong or hypotonia weak. Now, what are the ways to reflect the weakness? Now, you will be able to see whether the child, how the child is breathing. It may be sometimes decreased spontaneous movements. You can see the child. The child is basically flat. Is not using the movements of the spontaneous movements are decreased, and the child will have a very weak cry and poor suck. That's the bulb aspect. And then the facial expressions are not expected to that neonate. You might see it's very dumb, and child is not expressing their face to the sounds, to the lights, to the movements, to the surrounding. And especially the respiration. You can see child may be using the abdominal respiration instead of the usual normal thoracic and diaphragmatic respiration. So with these features, if you are very experienced and if you keep giving attention, in a moment you will see this child is hypotonic as a clinician. Having said that, you can see, you have to appreciate in the document that how you appreciate the spontaneous movements and how you appreciate the respiratory effect, and then the bulb, the cry, sucking, and the facial expressions. Now, there are recent publications to see that a thing called cough test. Child may be struggling to cough. So you can generate cough. What you can do is, you can apply some pressure on the trachea and wait for a single, and then child will cough and remove their secretions out of it. So you call it a cough test. Then you can see whether there are drooling, not only outside, drooling inside. You call it the pooling of secretions inside. So drooling can be outside as well as inside. So then that will be appreciated whether the child can't even use their bulbar elements to manage their secretion. Then the child will have a very weak cry, and you will see the abdominal breathing when you observe. So with these tests, that it will indicate that the child is weak in addition to hypotonia. Then you might use your knee hammer. You can see I told you whether they are a hyperreflexia, then it will be under central, or if it is absent, or if you can demonstrate fasciculation, obviously, then you are on the peripheral stream. So floppy strong, floppy weak. How did you differentiate? First of all, you demonstrated floppiness, then you demonstrated whether it's weak or strong with observations, and then with your knee hammer. Ultimately, now we are in two lines. Are we dealing with the central cause, or are we dealing with the peripheral cause? Now, when the child is much bigger, obviously, the child will be able to walk with hypotonic children, but they will not be able to jump, high jump, especially as it is expected, or we call it sprints. When they are running, that they will have difficulties in doing so. And based on that, we might say this child has some element of hypotonia when they are large. But in our topic is of course floppy baby, that neonates and infants, obviously these elements will not be, we are not privileged enough to handle that or to observe those things. So ultimately we are left with the observation and the tender knee hammer. And it is much longer duration, of course, these contractures and other things also will be helpful to judge. So as a clinician, we have very limited scope or limited elements to judge. So therefore, you have to build the confidence on observing and seeing these children when they are moving. So basically, in addition to these causes, what you can do is you have to differentiate whether it's a central cause or peripheral cause. So central causes usually you can see their level of conscious will be at the central. So therefore, there will be alterations of the consciousness when they are in central. But usually in the peripheral cause, the brain is intact properly and they are very alert children. But then the weakness, of course, in the central causes, the axial weakness is much more dominant than the limb weakness. And the reflexes, of course, I told you. And then you can see the power against the gravity rather than against the resistance because children are small. So based on that, now you're very confident that whether I'm dealing with a floppy strong or floppy weak. Having said that, we can see in this cartoon also, you can again and again confirm yourself whether we are dealing with a central floppy or peripheral floppy. So now we are in two lines, central causes, peripheral causes. Now we'll see under those two headings. Causes of hypotonia. Central causes, what are the central causes? Then what are the peripheral causes? So peripheral causes, obviously you can see muscle, the nerve head, then the nerve, then the neuromuscular junction and the muscle. So there are four elements. Brain, of course, I told you, the brain, cerebellum and the spinal cord. So these are the 7 elements of neurology. Now you can have clarity in your mind what element is dealing. That's why I told you in the floppy baby infant, this presentation is covering the entire neurology, and in the process of management, you will have the bulbar, maybe sometimes sphincter, and then the syndromes as well. Now, this is the cartoon that to display the central causes, obviously, when the tone regulation part is we are talking about. The brain regulation, obviously, the DNAs are supposed to be there. You should not have various other syndromes, so normal children. And then the metabolism of the body, the neurochemicals, and not only the neurochemicals, the disturbing other supplies chains like the metabolic, the sugars, and then the lipids, and all these metabolic elements, if they are not in the optimum status, this regulation will be in trouble. Then the injuries, obviously, if there's a trauma, it may be antenatal injuries, perinatal injuries, and obviously, then if there are structural deformities on the brain or the cerebellum or the spinal cord development will definitely reflect or with or without hypotonia. Then it is coming to the motor neuron, obviously the spinal muscular atrophy. We are not talking about when the motor neuron is being acquiredly damaged by polio. It's not under the topic here, the floppy infant. It's an acquired condition. It goes under the acute flaccid paralysis that comes on later life as acquired cause. And then you can go to the nerve. Nerve, of course, what we are going to see, the hereditary part of the nerve damages rather than the Guillain-Barré and other acquired causes. So basically what we are going to discuss is the HSMN, that is hereditary motor sensory neuropathies. And in addition to that, sometimes there may be mother's antibodies and are coming to the body, this body, and maybe causing some kind of interference for a transient period on this lower motor neuron element. And that will be really reflected on the neuromuscular junction. You can have congenital or transient myasthenia. Congenital myasthenias, of course, now you have to understand what are myasthenic conditions. Now, myasthenic conditions mean the neural pathway is an element had to transform into a chemical transformation or information pattern, and that should transfer down to the motor end plate of the muscle, and then muscle should read it, and then it had to get reflected down the muscle to act accordingly. Now, in this process from structure, chemical, and then again structure. So there's a pre-end plate, then the this chemical element, and then the end plate. So there are three elements in all. Now, what can happen is if the mother's antibodies, now you are very familiar with the myasthenia gravis, which is an autoimmune condition, and the mother's antibodies might go and cross the placenta and might have for a transient period, transient myasthenia gravis. But the so-called congenital myasthenias are basically not because of the antibody variations. Usually the antibodies are negative. What will happen is on the presynaptic or postsynaptic or synaptic cleft can have anatomical defect. Now, when there is anatomical defect, again, the neuromuscular transformation will take place in an inefficient manner. So they are called congenital myasthenia. So very clearly you have to identify myasthenia or neuromuscular conditions can come in various ways. One is usually the common thing that you all know is the myasthenia gravis, the antibody-mediated system. But if they are without generating they themselves, then you call it transient myasthenia gravis. Then coming down to the muscle, basically we have to know the two things, that is the muscle myopathies and then the muscular dystrophy. Now, the differentiation of myopathies and muscular dystrophies is that had got confused with the genetics, but basically the understanding is muscular dystrophies are degenerative, where the muscles are keep on damaging. But myopathies, other congenital myopathies, they won't basically get damaged, but there is a structural they are not fully formed as it is expected for a normal child. So therefore their power will be poor and they will have hypotonia. But again, there won't be a damage. But in muscular dystrophies, of course, what will happen is their muscle fibers keep on damaging. And because of that, the chemical inside the muscle called creatine kinase will join the blood, and we will be able to see the blood CPK levels, and based on that we can say whether the child is having muscular dystrophies or not to some extent. But it's not only the muscular dystrophies, this damage can happen because of trauma, due to metabolic conditions, or maybe infections. Then also the CPKs will go up. So the high CPK doesn't mean all the time it's muscular dystrophies, but in this kind of situation, if others are excluded, of course, we can think of muscular dystrophies. Now, how we are going to investigate is that we have to understand. I'm going to brief here because then I will have easy access in the latter part of this slide. Now, obviously, if this lower motor neuron, starting from the motor neuron, nerve, then the neuromuscular junction and the muscle, if any of these elements are involved, that will get reflected on the muscle. So when the neurophysiologist put a needle into the muscle to do EMG, that will reflect most of these activities. So if the motor neurons are damaged, that message will not come down to the muscle. So then the denervation will be felt through the EMG. They have the technique to identify the lack of messages down to the muscle. So the denervation will be felt. But if there is a problem with the transmission of the neuromuscular junction, then it will be differently read. So we call it repetitive nerve stimulation. Their muscle amplifications all will vary. So then the nerve conduction studies, the neurophysiologists will give that picture down to us. But if the nerve is damaged, the nerve has two parts. You have the axon and it is covered with myelin. So whether it's axonal damage, whether it is a myelinated damage. So the neurophysiologists, when they do the nerve conduction test, if the myelin is damaged, what will happen is the nerve will transfer the message, but it is slow. So there will be a latency. It will not do as it is normal. So therefore, they will have delays in the transmission in the nerve conduction, and then they will say there is a myelin damage. If there is axonal damage, what will happen is not all axons will damage in one go. So therefore, the damage axons, the percentage of the damage axon will get reflected on the amplitude. So then they will have a lower kind of a peak of the nerve conduction studies. So the EMGs and the nerve conduction studies are useful to differentiate these activities to a great extent. Now you are clear now what we are going to deal with. Now, Floppy strong, again, just to recapitulate the same thing, you can see increased tendon reflexes, extensor plantar reflexes, so ankle clonus, global development delay. Then you can see the Floppy strong is from the brain. There will be changes of the brain size, maybe microcephaly, macrocephaly, or there may be changes, there will be seizures, because now we are dealing with the brain. But if it is a Floppy weak, microcephaly, macrocephaly, whether they are going to be there or not, usually it's not there. And it's hyporeflexia, or maybe going down to the severity, it may be areflexia. And then what will happen is they will be very alert and they will have their social interactions are being preserved. They're nice children, but they're very weak in moving their limbs and the trunk. So this is, and then they are cry and the facial, the cry and then the respiratory will be paradoxical. So this is a very crowded slide, but you know, this is how we are going to differentiate. First of all, when there is a hypotonia, whether it's a neurological condition or systemic illness. Now, the systemic illness also you might have sometimes hypotonia when they are very highly septic, or maybe the metabolic pathways are not properly working, when there is trauma, when there is hypothyroidism, hypoglycemia. So when they are optimally, the neurology system is not being fed and being supported, then again you might have hypotonia. And coming down to the neurology per se, you can see we have differentiated to Floppy strong or the upper motor neuron, or Floppy weak, or we call it the lower motor neuron. And you can know the 4 elements of lower motor neurons and then the upper motor. Upper motor, of course, you can see most of the conditions may be genetically coming down, or maybe perinatal or postnatal situations might get reflected. Same thing in a much organized chart. You can see the central nervous system, so the chromosomal diseases, inborn errors of and the structural brain lesions, or we can chemical brain malfunctions can be. So therefore, the patterns of weakness might vary depending on that. So usually they are strong, but it might vary. There are other activities might vary. Then motor neuron, I told you, there will be generalized weakness because the nerve head is in trouble and the messages are not going to the brain. And often they spare the diaphragm, because of that will be abdominal breathing can be seen. I will show you videos. Then the facial muscles, pelvis and the sphincters might get affected. And the nerves, of course, when the HSMN or hereditary motor sensory neuropathies are caused, you can see the respective muscle groups are affected, and you will see not only the weakness, and it is lasting for a while, there will be some wasting also will be reflected. Neuromuscular junction, of course, a different spectrum. I told you they have a predilection, this neuromuscular, though neuromuscular, you might ask why the neuromuscular junction all over the body is not affected. For some reason, they have a predilection to the eye, to the bulb, to the respiratory, and to some extent to the limbs also. Then you call it the generalized myasthenia. But it depends on the predilection. It varies according to the condition. And muscle, of course, I told you, for these lecture purposes, the different types of myopathies and then the muscular dystrophies. So they will have weaknesses anyway prominent. And in the degenerative process in the muscular dystrophies, sometimes the regeneration of the muscles due to the degeneration may be reflected with other elements, fat and all. Then there will be various other reflections on the muscle architecture. Now you might wonder whether what are the commonest things. Usually, though we think that the peripheral causes are with 4 elements, peripheral causes account for less than 20%, roughly around 1/5 of the children are having peripheral causes, but mainly our hypotonic children are having a central cause. And you can see the detailed breakdown of it. The hypoxic ischemic encephalopathies account for the majority of the causes of the central causes. And depending on the situation, the genetic causes might vary. These are recent publications they have done, and the brain malformations, it varies. Here it says about 13%, study to study it varies. There are various figures, but in more or less, they are the hypoxic ischemic encephalopathy. Depending on your facilities or the neonatal facility, it might vary. Then the Down syndrome, Prader-Willi, all these conditions, Fragile X vary, and the detection power also in your system also will decide what prevalence that you are going to quote in this principle. But basically, it's 1 into 5, like peripheral causes are being reflected. Peripheral causes definitely coming to light because they will have difficulties in their living, they will have short lifespans. So because of that, they will get reflected more. And the spinal cord transection diseases, and the test that you can do is the MRI, and then the syringomyelias and other conditions. Again, you have to do the imaging to see MRI imaging, and now there are various techniques, AI facilitated and various other activities to detect all these things. The spinal muscular atrophy, of course, what we have to do is the nerve conduction test, and then we have to do the confirmation test with genetics. I will go into details in time. And then the peripheral causes, again, nerve conduction test I explained how important that is. And then the myasthenia gravis, of course, again, the nerve conduction test is going to be of help. And then the antibodies can be detected on the blood. And using all these techniques, you might classify what kind of myasthenia that we are dealing with, and the genetic test. Infantile botulism, and just for completeness, is I haven't seen a child with infantile. Again, the same thing in nutshell. You can see the floppy strong children are going basically for the investigations like imaging, CT, MRI, and for the genetics, and then the metabolic tests are being used in order to diagnose. And floppy weak, of course, the nerve conduction tests are much more useful, and then that also will be coupled up with the genetic test. And then we might do some antibody test on certain myasthenia. You can see the same thing in big picture, how you are going to differentiate. So blood levels, the CPK levels, and the antibodies, depending on this cost of the test and all, had to be considered. That is why I'm showing all these things. You should not do all the tests on all patients. We have to differentiate. We have to say, demonstrate all this clinically and see whether the floppy is strong or floppy weak. And then with these basic tests, we have to see what area you are dealing with, and based on that, you go for basically genetic and other expensive chemical tests. So hypotonia strong, the central hypotonia. I told you hypoxic ischemic encephalopathy to some extent can be prevented, not all. And whether there's a brain insult or hemorrhages or chromosomal issues on metabolism can be detected. So as you said, the radiology may be taking place, unlike in now more and more that is used, because that will differentiate further. And ultimately, if you can detect malformations, of course, will be, and then again that will give a lead to think of mitochondrial diseases and the brainstem defects, and then other kind of metabolic conditions. Usually, when we were senior registrars, we used to my MRIs were not that abundant, so we used to have this principle of various techniques to differentiate. But now, of course, they go for MRI and that will direct you to do what kind of metabolic test and genetic test to be done. So this has come as a forerunner of most of the genetic and metabolic tests to limit number of tests that we are doing and to do it in a much more focused manner. PVL, of course, in the HI, you can see, you might have seen on the ultrasound, you can see, and then on MRI also you can see to detect. And if there is PVL, no point you do various other metabolic tests and other activities because it's very obvious that then you can diagnose the cerebral palsy or diplegic cerebral palsy accordingly, and then you can act accordingly. Various other structural abnormalities of the brain also might limit your other type of investigation. You need not to do nerve conduction and all these things on this kind of children. LPs and other things can be prevented because of these activities. And you should not miss doing thyroxine levels, and recently it was added with vitamin D levels also, if the child is beyond the breastfeeding era, whether the vitamin D levels are also being tested. That's something that you can treat. And it's a treatable condition you should not miss as any clinician at even the primary level. So other laboratory tests, creatinine kinase is not that expensive. You can differentiate the muscular dystrophies and other activities, and acetylcarnitine and carnitine tests are beyond that comes to the next level. Basically, when they come, as I told you, you have to see whether this hypotonia due to a systemic situation. You should have to do the sepsis work and the electrolytes and the urine levels of sugars and other activities. You can drug levels and other things you can test, and then you can see for torch screen and other activities depending on the findings of the MRIs or the CT scans and the clinical history. Then you might go further to do the karyotyping, or maybe beyond that, there are certain other genetic tests which are available at the moment. So you can go beyond. Metabolic test, of course, amino acid level, lactate, pyruvate, ammonias, carnitine profile, very long chain fatty acids are options available depending on you need not to do everything in one go. You have to kind of narrow it down with the other investigations and the clinical skills, and then you have to do these tests. So syndromes, of course, Down syndrome is very, almost everybody knows this. Then these are the features, the clinical features that they have. I'm not going to deal with that here. The Prader-Willi syndrome is another condition that you might miss, and they are hyperphagia and hypotonia in infancy, and later on they change themselves, and with these clinical features you might. And OMIM is another website that you can use to diagnose these patients, and the gene review is another website that you can use. But now there are technology with phase 2 gene. There are apps on the mobiles that when you hold your mobile phone to the child's face, they will give possible diagnosis on the app itself. So based on that, you might even know these features, but even without that, now the possibility of diagnosis with the AI technology. And then the Fragile X, of course, a lot of people are missing. And then the Selvager, these are various clinical syndromes that you cover under hypotonia, Angelman syndrome, various other syndromes. This is an interesting condition too, but you can see that if you see appreciate the arrow, you see like a molar tooth. So, and that appearance is basically, you need not to do other investigations if you have this appearance on your imaging. And then you can diagnose the Gilbert syndrome and Kabuki syndrome. So multi-system activities, as I told you, the neural system also to be facilitated with their energy sources, glycogen and the mitochondrial and other activities. And then the enzyme and other activities need to be facilitated. So if there's problems with any of these things, we call it under the metabolic diseases. You might have hypotonia as a part of the disease process. And there's another element called benign congenital hypotonia. To be honest, when you can't detect any of the causes, it may be possibly a microstructural problem of the anatomy of the muscles and other activities or the brain regulation mechanism, and we call it benign congenital myotonia, and it's a diagnosis of exclusion. So coming down to, I will take very short time to complete this. Also hypotonia weak, the peripheral hypotonia. And I'm going to touch 4 elements. First is the SMAs, then the HSMN, and then the neuromuscular junction and the muscle. So obviously, out of these elements, we are not going to cover the acquired conditions. Basically, we are going to consider the genetic or earlier on conditions rather than. So SMAs, of course, you can see it will have, I will skip this slide. So obviously, when you are going to deal after relieving from the central hypotonia, you come to the periphery. I told you the CPK levels. And people, even when the CPK is in their test going to 600, 700, people get alarmed and thinking muscular dystrophy. So usually the CPK levels are around 300. So it should be at least 10 times more, maybe at least 5 times more for you to be considering that the CPK levels are high with regard to this kind of diagnosis. But you can have mild CPK increases when you have exercised your more, or maybe myositis and other conditions. The CPK levels also can go up, need not to be an underlying condition coming under this setting. So creatine kinases, EMGs, I told you the importance, the muscle activity will be reflected, and then depending on that, you might go for DNA or other kind of genetic test. And then we rarely now do the muscle biopsy because of the genetic and metabolic, and EMGs are much sound in diagnosis, and so we avoid mostly muscle biopsies unless there is a specific cause to do. So spinal muscular atrophy, as you know, there are conditions. SMA 0 is recently described as antenatal, the most severe form. They don't live until 6 months. And the SMA 1 type, Wadnik-Hoffman type, and they are never to sit type. They will succumb earlier on, so they will never sit, and it's because of the, we call it the genetically survival motor neuron genetically missing. So because of that, the motor neuron will not be able to survive, and ultimately you get the SMA type. So the SMA type 2, never to walk type, and they are come much later. And then the walking type, or the SMA 3 type, you call it Kugelberg-Wallender disease, and then the adult type SMA with fairly lengthy lifespan as well. That comes. And recently there are 2 other conditions, Pickle type SMA and smart type SMA are described. So I'm going to just fast touch on that. The never to sit type, you can see SMN1 gene, SMN2 gene, never to walk type, and SMN3 able to walk, but have the same thing with regard to the progress of the disease and then the prognosis of the disease, and their life expectancy is depending on their severity or the type can vary. And then they are alert, and we will see some videos on that. So obviously you can see the nerve head is damaged, then ultimately the axons will get damaged slowly, late, and then ultimately the muscle will also get atrophied, and that will get reflected. You will see fasciculation, especially the tongue fasciculation. But in the SMN gene, I told you, if there are SMN2 more and more copies, then their survival will be safeguarded beyond the expected level. So SMN1 gene, as well as we have to do the SMN2 gene to see the prognosis. I will come to that in a minute. So basically you can see that the anterior horn is damaged. So you can see how they are looked at. This is one of my child. With their permission, I am showing the tongue fasciculation, which is looking at it. See the tongue fasciculation, the punching like in the muscle, some fibers are, so inhalation is causing them to cause fasciculation because they are not adequately supplied with the nerve. So nerve heads are being damaged. The SMA type 0, which was described very recently. You can see the child again, same child. You can see the abdominal breathing nicely demonstrating, and the chest is not really moving to that extent, and abdomen is, so the diaphragm is used to breathe. You can see this is the difference that the chest in a SMA child, the chest will be so slow and slow. It will get. You can see, you can appreciate when in this view that you can call it a bell-shaped chest. So the chest rather than the chest, you can see the abdomen is moving, abdominal breathing. So the same features
Learn to
are
spot
being,
the warning signs.
I will skip this
Floppy
slide.
baby.
You can see
Head
on the, you
movement can
go
be
to the slide
particularly
and see
tough for a baby with
same thing.
SMA.
I have already
Here,
described
she's unable
how
to
they
lift
look
up her
at,
head while lying on her
and,
belly. Does your baby
then
seem floppy? When you pick up your child, does it feel like she will
lift
slip
up.
out of your hands?
You can see.
Can she lift up and hold her
Same
head during
manuals
tummy time?
that you have
Most
already
babies can
furnished
lift their
at the
heads
moment.
briefly, turning them
And you can
side to
see this
side within
video
the first
actually.
month of their
And again, SMA child. This is how you can see how alert the child is, looking around, but only problem is he's struggling to move his limbs. And but child is the tongue fasciculation is seen, and the child is very alert, and she can resist any movement that we are doing from outside. And these are genetically ultimately diagnosed. In the process of genetic diagnosis, something what you need to learn is this SMN copies. 0, 1 copy or more than 2 copies is for your survival. But survival motor neuron genes, if you have SMN2 gene, that will decide your prognosis. So SMN1 as well as SMN2 genes. Now you can see if you have more and more SMN2 genes, that you will go from type 1 to type 4. So when you are independent walking is achieved if you have more and more copies of SMN2 genes. So that will look after your prognosis. This is SMN type 3 child, walking child, but you can see the hypotonia. And then the management part is not supposed to be done in this lecture, basically only the approach. So we have to have multi-model approach to the management part, the pulmonary, acute care, other involvement, medications, nutrition, orthopedic, various activities. It will be another topic altogether, and then the consequence like scoliosis and other things have to be dealt time that's not covered under this lecture. So there are treatment guidelines on the spinal muscular atrophy, how to feed the diet, breathing health, or how you are going to have assisted equipment. Various technologies have been brought in, exercise and stretch and spinal problems. So these are medicines that you are going to use. And only one drug I would like to see is this drug is being tried at the moment. It's very, very expensive. And there's a lot of political debate is going on. Even Western countries can't afford this drug, and it's very, very expensive. So HSMN in very nutshell, I told you what will happen is there are various types being described. Is the nerve damage, and you will have to use the nerve conduction test to damage, and ultimately the typing will be done by genetics and other ways. So there are various types described with the other clinical features, and HSMN, what I want to tell is you can have their foot deformities are really guide you to think of HSMN, and you can see the high arch on the, and then we will diagnose both legs are affected. Myasthenia, hypotonia, of course, what you are supposed to know is the congenital myasthenia. As I told you, it's the anatomical damage to the synaptic or presynaptic or postsynaptic membrane. And it's a complete topic altogether. We'll do later on. Then the neonatal transient myasthenia due to the antibodies coming through, and familial infantile myasthenia is the other condition that you need to cover. So then transient acquired neonatal myasthenia that we have to think of with infantile version. So they will be generally weak, and the fatigueness and the fluctuation is the crucial thing that you may be able to differentiate. But that is not that easy in the neonatal practice. You might miss the doses and other feeding difficulties. So therefore, there is high chance that you might miss. But anyway, having high degree of suspicion and the maternal histories will basically guide you to think on possibility of myasthenia gravis. So these clinical features will not be very typical by the time you see as a floppy baby. So, and how we are going to differentiate from SMA is another challenge, and then you go for the neuromuscular junction. So fatigability of the toes is these privileges will not be only available when they are big. Various techniques these are impossible with the neonate or with the infant. The various abduction of arms, asking them to count, all these things for big children. So the confirmation will have to be done with fatigability test, with eyes back test. All these things are for big children. You have, of course, high degree of suspicion, and the other kind of genetic and neurophysiological test will ultimately diagnose the myasthenias and antibody test. So I will skip myasthenia and come to the muscle. And these are the varieties of various you can see DOC7 and various types of congenital myasthenias have been discussed. And the management is varying, not the pyridostigmine. Sometimes they have pyridostigmine deficiencies. So giving acetylcholine esterases, acetylcholine deficiencies. So management will vary accordingly. And so that's a completely different topic altogether. And they are classified into 5 classes. Muscular hypotonias, of course, again, congenital muscular dystrophy, congenital myopathies, and then floppy baby, that will be detected by the muscle activity, by the nerve conducting the EMGs, and then appropriate other things. So I think I will stop at that point. And management issues, of course, hypotonia is another topic altogether. And I have touched only the approach to diagnosis, and this part is for another lecture. I think management part, obviously, it had to be a multidisciplinary team had to get involved, obviously, and not only the clinicians, but also the therapist. And the technology is now being highly used, so the technology involvement also there. I think these are the future expectations. And very importantly, as clinician, what I have to tell is you can still say with all this technology and all this material, all these diagnostic technique, the history and the physical examination is generating the highest diagnostic yield. That is why this floppy baby child, the diagnostic part, and those tests are very expensive. Therefore, we have to decide what test that we are going to do. So thank you very much for the kind attention. So in summary, what I have dealt with, I will explain what is higher tone and then the hypotonia, how it is regulated, and clinical demonstration of hypotonia, clinical demonstration to differentiate the weakness in order to bring it under the floppy, strong and weak, and then how we are going to develop a diagnosis and then the care plan. Thank you for patient listening, and any questions can be entertained.
There's some questions like how early physiotherapy or occupational therapy should be started in a floppy baby?
You can. I think there is no kind of hard and fast rules because it depends on the situation. Because if you are going for cerebral palsy and early diagnosis of cerebral palsy with diplegic core, then cerebral palsy itself is not one disease. But though we put it under one heading, if you take hemiplegic cerebral palsy, that is also right and left, is entirely different. Their pathophysiology is different. Their parental, I think going up to the parental expectation is different. It's different diseases. So based on that, whether we are going to do physical therapy or other activities, all differ. So there is no one answer to that. Earlier diagnosis, earlier intervention is what is necessary. And then again, what type of physiotherapy that you can do, especially when they are floppy weak, that itself had to be tailor-made to that condition.
Oh, thank you, sir. Then there's another question. What type of infections causing floppy child?
I told the torch infection is being taken care of, and various other infections have been now as a floppy infant or neonate is, of course, the perinatal. Any infection might ultimately lead for sometimes structural damage or chemical damage to the brain. So you can't specifically say what infection. So torch plus other perinatal infections might have floppy infants and floppy neonates and floppy infants.
Then what are the referral indication in primary care?
If you see hypotonia, I think it's had to be referred because it had to be dealt at least at a level of a pediatric level, because obviously you can see, you have to see the diagnosis and you have to confirm hypotonia and then confirm weakness and then appropriate diagnostic interventions and the management intervention have to be done. So primary care, if you suspect this, if you, especially through the posture and other activity as I showed you, if you see that kind of situation, quickly you have to refer.
And can drugs used by mother cause floppy
Yeah.
baby syndrome?
Yeah, I told you.
Yes.
Yeah,
Yes.
drug history is important. Drugs and even the diseases of the mother can cause floppiness on the child. Yeah, definitely, yes.
Okay. That's all, sir. Thank you very much, sir.
Thank you very much.
So you can find the link in the chat box, and you can fill it now, and you can kindly give us your feedback. So thank you all for joining, and thank you, sir, very much for doing the lecture today.